Hi, everybody. Thank you so much for joining me today. It's really always my pleasure to join in on these conversations with my endodontic community. So thank you so much. And I hope you enjoyed this quick session on my conversation, investing in endodontic technology to save more teeth. So a few disclosures before I get started. The opinions, recommendations, and best practices given during this presentation do not necessarily represent the opinions or recommendations of Sun Endo, but are a compilation of my own personal experiences and solely my opinion. And I am a key opinion leader for both Sun Endo and Dentsply Sirona, so I just want to put that out there. To give you a little bit of a brief background about me, I am Dr. Sonia Chopra. I am a board certified endodontist. I graduated from dental school from the University of Maryland in 2003. I then did a GPR in New York City at the Long Island College Hospital, which is actually in Brooklyn, New York. I stayed in New York City for a few years and I practiced as a general dentist from 2004 to 2006. And that's when I realized my love of endo and the fact that I wanted to be really good at one thing. So I moved to South Florida and I did a endodontic residency at Nova Southeastern University where I graduated in 2008. From there, I moved to Charlotte, North Carolina, and I started my practice from scratch, and that's called Ballantyne Endodontics, and I have been there ever since. So as the years have gone by and my practice has grown, I have really kind of attributed my practice growth to one thing, and that's investing in endodontic technology. I've always considered myself an early adopter of things, and I think it's always been to my benefit. And I'm so glad that I've done it because I really feel like now we have the perfect trifecta to create this modern day root canal that I call all the time. We started our training in residency using the dental operating microscope. As soon as after I graduated from my endo residency, the cone beam came out. And the moment I got enough money to be able to afford a big high ticket item like that, I invested in the cone beam. And that was back in 2012. I first heard about it in 2009, but then in 2012, I really took the plunge because I could do so. I opened my practice in 2008. So 2009 was not going to be the year for me. And I think we all know now the benefit of having cone beam technology within our endodontic practices. And now the same thing I can say about the Gentle Wave. I have had the Gentle Wave in my practice for about 2.5 years. And every day I think I learn something new about what this technology can provide us. And I'm happy to share with you a very important case that, again, just opened my eyes to the power of all of these pieces of technology together. So I'm going to call this a tale of two teeth. This is a patient who arrived in my practice back in 2017. This was the very first radiograph that he had in my practice. He had no pain whatsoever. His dentist simply found a radiographic finding at his cleaning appointment. He never had pain. He had normal probings, normal palpation, normal percussion, and had no response to cold on the teeth because obviously teeth number 30 and 31 were root canal treated. So you can see that there's some mesial resorption actually occurring on 31. So we're not looking at 31 in this case. We are looking at tooth number 30. And I was able to diagnose the tooth with previously treated tooth and asymptomatic apical periodontitis, tooth number 30. Let's go a little bit deeper. Here is the cone beam that I took back in 2017 at his initial appointment. Again, no pain, no problem. He didn't even know that this was there, but the cone beam definitely shows that nice outline of that periapical radiolucency on the mesial root. Here's the axial view. Anytime I have a lesion like that on the mesial on a lower molar, I'm always going to consider that there could be a middle mesial canal. I don't really see anything crazy, but there's enough distance in between the mesiobuccal and the mesiolingual canals that you could appreciate there could be something there. Here is the coronal view. Again, you don't really see a lot of bone loss in this section. And just for reference, I do take my cone beam snapshots with the crosshairs within the long axis of the tooth. So this is directly centered. I don't have those crosshairs showing in these images, but just for reference, know that that's where these slices were taken, right? So that this was right in the middle of that mesial root. So I didn't really know what the disinfection protocol was for the previous treatment. I don't know if a rubber dam was used. I don't know if full strength bleach was used. I don't know how long it took the patient to get the crown on this tooth after the root canal was performed. So I decided to retreat thinking that there was just simply a contamination issue. And my hope was that I could just refresh the gutta percha, give it a nice wash, and then repack it, and everything would be fine. And just FYI, tooth number 31 has been extracted because of that mesial resorption. And after I did treatment on this patient, I didn't see him for several years. He actually came back to my practice this year in 2021 for a different tooth. And as I've learned, whenever I see my patients again for another tooth, I'm always going to try to get a recall or at least some x-rays of the previous teeth that I have done on them before. So that's exactly what I did here. And I see that he missed his 1-year recall appointment with me because he, again, never had pain with this tooth, but you can still appreciate that periapical radiolucency is still there on the mesial root. I took another scan at the recall, and you see that really nothing has changed. So now my conversation with the patient is going to change. 2 orthograde retreatments have not worked. So now we have to switch to something surgical, either an apicoectomy or an extraction. So that was part of my initial conversation. But since he was here actually for the contralateral tooth, I told him, let's kind of just hold off on this discussion. Let's treat your symptomatic tooth, but I want you to be aware that you still have an active infection going on tooth number 30. So again, nothing much has changed between 2017 and 2021. The lesion is still there. Okay, so let's flip and go to the other side. He was actually referred in 2021 for tooth number 19. Again, he has had root canals on 18 and 19. Both have been restored. 19 was actually done by a neighboring endodontist, and I can't knock the treatment. Nothing was really done wrong, but he is symptomatic to percussion on this tooth. Probings are normal, palpation is normal, but he can't chew on this tooth. So I diagnosed tooth number 19 as previously treated and symptomatic apical periodontitis number 19. And you can appreciate that there's just a small lesion happening there. Isn't that crazy that that giant lesion on number 30, not really causing much pain, but this tiny one on 19 is really troubling the patient. Here's the off angle. And I'll go back one slide just to see, like, I felt like working length was really well managed in this case on the mesial. But if you take this off angle, maybe there was a patency issue on the mesial root. So those were the kind of things that were going through my head. How could I improve this with another root canal on the tooth? Here's the bite wing. Doesn't show me anything that's kind of crazy or out of the ordinary. And again, the comb beam, just to take you in a little deeper so you can see that the lesion is there. And again, it is pretty symptomatic. It was like a 2+ to percussion on this tooth. And so he really wanted this treated. Here's the coronal view of the comb beam on 19. And again, the axial view. So I'm going to retreat the tooth. One thing I can do differently now is that I do have a gentle wave. And so besides doing, the normal cleaning and shaping, I also wanted to make sure that I was very patent on the teeth just to confirm patency. And you can see my gutta percha is a little bit long, so patency is there. I ran the gentle wave, and then I obturated the tooth, and this is where I got surprised. And you can see that the sealer was able to pick up this middle mesial canal that branched off one of the mesial roots. And this is probably the same thing that's going on the other tooth. So I was really quite surprised that I picked up this anatomy and that the fluid dynamics of the machine was able to get in here and adequately clean. And here's just a different angle. But I think that there's a lot that we can, I like to call it the extrapolation from the obturation, because now that I see the way 19 was obturated, it has totally made me repivot my treatment plan on tooth number 30. The likelihood that there's a middle mesial canal on number 30 is pretty high. Things are bilateral in nature, correct? And so now, instead of subjecting my patient to something surgical, I want to go back and do another orthograde treatment and see what gentle wave can pick up and what it can disinfect with the fluid dynamics. So again, I think for the future for this patient, what does this mean for tooth number 30? Again, things are bilateral in nature. So based on what I saw in 19, I'm going to assume that there's a middle mesial canal causing that trouble, probably also mid-root, and that's why I couldn't see it. I do trough every lower molar between the mesials to see if I can catch a middle mesial canal, but I couldn't see it, not in either one of these teeth. And I'm grateful that we have this type of technology that we can save even more teeth. So again, I've decided to retreat tooth number 30 again, using gentle wave to see if I can improve this tooth's prognosis. The patient still knows that the apical is still on the table, but he understands and he believes that I'm trying to avoid surgery and even extraction at all costs. There was definitely more to this patient's tooth story than it seemed. And anatomy like this is exactly why some treatments fail and why so many people think that certain teeth are cracked when they're really not. It's anatomy. It's anatomy that's harboring more bacteria. And if I hadn't had my gentle wave in this situation, I wouldn't have been able to also tell what was really going on with just this one and maybe even possibly two of these teeth. I can't wait to retreat number 30 because I'm really hopeful that the gentle wave is going to save this tooth and save this patient from a surgical procedure. So investing in the best technological advances in endodontics allows me to successfully treat so many patients and to save more teeth. For me, it's not just about the importance of the technology, but it's about the importance of the awareness of the technology and what it can do for us as endodontists. When we can share this information with our dental communities and they can see the difference that we can make for their patients, I think that really helps. So that referral education is really key. And it's really key for us to keep improving that awareness within our communities so everybody knows what is possible amongst our root canals. I want to thank you all for listening to this little quick discussion on endodontic technology. It's really always been an honor to be amongst your presence. So thank you so much. And if you want to connect with me further, you can find me on Instagram at Sonia Chopra DDS. You can find me on Facebook at Sonia Chopra DDS Endo for All. You can also email me at sonia@soniachopradds.com, or you can find me on my website at soniachopradds.com. Thanks so much for your time, and I will see you later.